Thank you. Thank you, Rima. I shall be talking about primary vitreoretinal lymphoma. When we talk of the classification and nomenclature, intraocular lymphomas could be primary or the secondary. Primary are essentially the subset of CNS lymphoma and mostly involving RPE, retina, and vitreous. Important to remember that 60 to 90% of them will involve the brain secondarily, and 15 to 20% of patients who have CNS will develop PVRL. These secondary intraocular lymphomas arise out of CNS and involve uvea and choroid. The secondary involvement of vitreous, retina, and RPE by systemic lymphomas, however, is rare. When we talk of the etiology or translational value of the etiology, there are two important points which we need to know. One, malignant B cells of systemic origin. Selective molecules migrate and home to CNS, and second, mutation facilitates the clonal growth. There is also theory that Epstein-Barr virus infection of the B cells causes their immortalization, which suppressed T cell function leads the Epstein-Barr virus infected lymphocytes to evolve towards malignancy. So how these lymphomas present? This is an example of a 67-year-old woman who came with bilateral blurred vision, 5 months duration. Vitreoretinal lymphoma was suspected. Patient underwent vitrectomy. Important to know about IL-10-6 ratio. In this case, IL-10 was higher than IL-6. It was a case of a high-grade non-Hodgkin's lymphoma. Important to do MRI because contrast-enhancing lesion was seen right there in the right gangliocapsular complex. A stereotactic guided biopsy of that gangliocapsular space-occupying lesion was done, which showed atypical cells positive for CD45, CD20, MUM1, and negative for CD3. And we also did the whole genome viral load, which was positive for Epstein-Barr virus. So the final diagnosis was primary CNS diffuse large B-cell lymphoma of the non-germinal center B-cell type. So important to remember about this little pathogenesis. Epstein-Barr virus may have a role. It doesn't have implications in the treatment, just in the diagnostics. The third point which we need to remember is that VRL can mimic several ocular diseases, including infections, especially in country like ours. When we did a study long time ago from India, we reported that average age of onset of lymphoma in India was 55 years, and interior uveitis nearly half of them had, and 40% actually had retinal vasculitis. This is an example of the lady where I won't call it vasculitis when I look back, but at that time we thought it was vasculitis. With vitritis, test for TB was positive. We treated her, she did not respond, and 10 months later she started developing these patches suspected of lymphoma. At that point, we did vitreous biopsy, which was negative, but then 12 months later, repeat biopsy, subretinal aspirate, she came out to be positive for lymphoma. So large B-cell lymphoma, initial biopsy may be missed. However, 24 months later, she did develop CNS involvement, for which systemic chemo and radiotherapy was given. Now the question is, what causes delay in the diagnosis? The problem is the patient initially might have just floaters and hazy vision, diagnosed as vitritis. So you don't really look for lymphoma at that time. Patient responds to steroid. When you give steroids, the lymphoma responds, and much later in the course when these typical tigroid spots appear and you see these bumps in the RPE, that lymphoma is suspected. So these are some of the pointers. The early use of steroids can mask the disease. The fifth point to remember is that clinical signs and imaging biomarkers for early diagnosis, we need to know them. Any patient with floaters, painless loss of vision, where the vitreous cells are kind of organized in the form of sheets or clumps, one has to suspect lymphoma. Retinal lesions are kind of easier because they are multifocal, they are creamy, whiter in outer retina, and when we do autofluorescence, we do, the appearance of leopard skin and severe vitreous infiltration. This is the kind of the vitreous infiltration that we see. Alessandro has beautifully described them as aura borealis when you see it under the slit lamp. Multimodal imaging is very helpful. This stippled hypofluorescence. OCT show FFA if we do, it shows granularity with late staining at the RPE level. So this granular pattern, OCT is important, the nodularity of the RPE, because these deposits are under the RPE and one may have outer retinal hyperreflectivity. Many times there might be a little confusion with retinitis-like lesions like this, but we have to remember that lymphomas have rounded roof configuration like this and subretinal deposits like this. These are the features which are very typical for possibility of the case being lymphoma. Now the last leg is, well, we have suspected, how do we make the diagnosis? The answer is diagnostic vitrectomy. Anterior chamber rarely has cells, so mostly it is the diagnostic vitrectomy. Important to discontinue oral steroids for 2 to 3 weeks before surgery. If local steroids have been injected, it's good to wait for a few weeks to allow more vitreous infiltration before doing surgery. Intraoperatively, we prefer small gauge. Sclerotomy closure has to be done with absorbable suture, and sample collection with undiluted samples, immediate lab transfer, IL610 ratio, mid-88 L265P mutation analysis. This is example of the case that I showed you, had vitreous infiltration with Ozurdex implant somebody had injected. At that point of time, IL610 was raised, but we got the negative cells. We did not get any. However, when we repeated the biopsy after 2 weeks, because we had removed this implant in the first surgery, it was a clear-cut case of lymphoma. So you don't need a lot of cells to make the diagnosis. Even a single atypical lymphoid cell is enough to establish the diagnosis. This was a kind of atypical case, but it was a case of lymphoma. While doing biopsy, important that these debris are very attractive. We all, as a surgeon, chase them. But we need to understand that lymphoma cells by nature are non-adherent. So when we are chasing these debris, we might be chasing more of inflammatory debris rather than the lymphoma. So it's very important to take the sample from the clear fluid as well. Treatment-wise, MRI brain to look for systemic disease is very important. No systemic involvement, unilateral disease, you might consider local therapy. No systemic involvement, unilateral disease. Systemic therapy, is kind of difficult to give, but if we have a bilateral disease, then we always treat it as CNS lymphoma. There is a role of debulking the lymphoma while you are doing vitrectomy, so just don't do the aspirate, just debulk whatever the debris are so that while treating, your need for chemotherapeutic agents will reduce. So this is the local therapy, it's a Mayo Clinic protocol, nothing that I have to add. There is a fixed protocol of when and how to inject. So Lastly, there is a concept of minimal residual disease, because earlier we do have the local therapy, but we really do not know when to stop. So if you have few residual vitreous opacities, now we have started tolerating them and inject only when the yellow spots appear. So this is how it is. The diagnosis is ophthalmological simple. You take the eye sample, cytology, immunohistory, cytokines, look for the presence of MRI, which even if it is normal, you may have to repeat every 3 months. Therapeutic options, local is methotrexate, rituximab, radiotherapy. Systemic treatment, if CNS is involved, if CSF shows increased IL-10, or if the disease is bilateral, de-Angelis protocol for CNS. Thank you very much, Rima, for the opportunity once again.
About a month back, I saw a case of 30-year-old man, young man, who had bilateral intermediate uveitis. One eye has dense vitreous. I treated with mycophenolate mofetil and steroid. He didn't respond. I gave biologics, didn't respond. Then I thought a sixth sense, I thought that it could be lymphoma. I asked them, he was not ready to do biopsy here. I got it biopsy in Ahmedabad, and it was a lymphoma. And then left eye, right eye developed vitreous opacity, dense vitreous opacity in 2 weeks' time. And then right eye did vitreous biopsy, that also showed lymphoma. So it's not it's uncommon but not rare to find a lymphoma.
Right. And we are seeing it in younger patients these days.
And the only suspicious at that stage will be the not responding to steroid. Right?
Not responding to steroid, the vitreous organized in the form of the sheets. When you see it on slit lamp, you see a sheet-like condensation. That's a very important. No synecdoche. It doesn't form synecdoche. So that's very important. No snow banking, you know. So they look a bit different from the usual intermediate uveitis.
And it can be unilateral or it should be bilateral?
It can be either. It can be uni or bilateral. But you see more cells in the vitreous, more sheets, no cystoid macular edema, you know, no synecdoche. So that is when you think it's something unusual.